Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. We are disseminating the National Guidelines for HIV Care and Treatment 2021. We are into the 17th session today, and the topic is HIV and Opportunistic Infections, Gastrointestinal System. We have with us today Dr. A.K. Puri sir from NACO, Dr. S.K. Guha sir from COE STM, and Dr. Jaya Chakravarty ma'am from COE BHU. We welcome you all for today's session. I now request Puri sir for opening remarks.
Good afternoon, everybody, especially our esteemed speaker, Dr. Guha, Dr. Jaya Chakravarty, participants from SACS, ART, and I hope I am audible.
Yes, sir.
Yes, sir. Yes. And my NACO team. In this session, we are going to study an important session regarding the gastrointestinal infection. And in this system, there are many gastrointestinal infection, right from the oral cavity to till anal region. And the most important is the patient.
Sir, can you please unmute? Yes.
Sorry, there was some call in between. So,
So please unmute. Participants are requested to kindly bear with us.
yeah, sorry for the disturbance in between. So I was talking about the various gastrointestinal infection, right from the candidiasis. It could be oral candidiasis, esophageal candidiasis, angular stomatitis, oral ulcer, which could be Ephthus ulcer, herpes simplex, Kaposi sarcoma, and further there are diarrhea, various kind of diarrheas. Diarrheas are very common in the common presentation. It may lead to the weight loss and dysphagia, and the most common sign and symptoms with which the patient presents are they are generally presenting with dysphagia and the painful swelling, difficult swelling. As a result of that, I mean, amongst the adult, they stop eating or take less food, and also as a result of that, weight loss is also there. And amongst the children, now it may present with the vomiting also. Vomiting and diarrhea is common, and then various symptoms are there. So these things needs to be taken care of, and if you take the treatment, I mean, if the patient is linked in time, timely linkage is there, timely diagnosis happens, then these diseases, these problems will be comparatively less, because majority of the infections are happening because of the low immunity. Leakage should be done as early as possible. So now I hand it over to Dr. Guha and Dr. Jaya Chakravarty. Thank you. Thanks for giving me an opportunity. And over to Dr. Guha. Thank you.
Thank you for. Yes, sir.
Yeah. Thank you, Dr. Puri, for the introduction. And this is today's session. I understand there are three faculties other than Dr. Puri. It's Dr. Jaya Chakravarty and myself. So I'll be passing through the initial section, and then Dr. Jaya Chakravarty will be doing the large bulk area. Next slide, please.
So can we quickly run through the pretest, please?
Oh, sure.
Thank you, sir. Kiran, sir, can we have the pretest, please? The pretest questions are now visible on your screen. There are 4 questions in all. Please scroll through the questions and answer all the 4 questions. Participants are requested to kindly start attempting the pretest. Kiran, we can end the e-poll now. Participants are requested to kindly attempt the post-test also at the end of the session, as your attendance is being recorded as per the post-test. I now request Guha sir to please begin the session.
Good afternoon, everybody. And this combined session, as we all know, that the gastrointestinal tract, the manifestations of HIV disease or involvement of HIV disease is basically protean. Considering that the gastrointestinal tract provides the largest surface area between the environment having the various pathogens and is the interface between the environment containing the various microorganisms or pathogens and the interior of the body of the people living with HIV. So that's why we get to see a large number of gastrointestinal system, which starts from the mouth to the anus. So that's one thing that we need to remember. In our day-to-day practice, majority of the PLHIV would have some gastrointestinal symptoms. And basically, with this background in mind, what all we are going to discuss today in this session is a talk a little bit about the oral manifestations, different oral manifestations that is commonly seen in HIV disease like Candidiasis, angular stomatitis, Chilitis, different oral ulcers, Kaposi's sarcoma, necrotizing gingivitis, etc., non-Hodgkin's lymphoma, etc. And also there will be segments. I'll be dealing with the oral pathology segment particularly. Majority of the other sections will be dealt with by the Professor Jaya Chakravarty. She'll be dealing with the diarrhea and of both small bowel diarrhea as well as large bowel diarrhea, how to differentiate them, what are the pathologies involved in, what are the microorganisms involved, what are the atypical protozoas that are involved in diarrhea in PLHIV, both in adults as well as in children, and the differences between diarrheal consequences in adults as well as in children, and the management. In addition, she'll be also dealing with the anal lesions, which are also very important and often a neglected part in clinical examination of PLHIV in the day-to-day clinical practice. Next slide, please. I think, yeah. So, as I said earlier, that the gastrointestinal disorders are amongst the most frequent complaints in PLHIV. In addition to perhaps it would be very close to the respiratory symptoms. And this is, we all know that the gastrointestinal manifestations are often very much non-specific and very difficult to differentiate them clinically, whether it's in vomiting, whether it's a dysphagia, whether it's a diarrhea, whether it's in pain abdomen, or it's an oral sore, etc. And we need to remember that in immunocompromised patients, multiple infections are often the rule rather than exception. So you might come across quite frequently multiple gastrointestinal manifestations. Say, for example, you have got candidiasis, you might also have some HSB stomatitis. Similarly, the patient might also having diarrhea due to cryptosporidial at the same time. So these are also very important things that we need to remember. Next, please. So if you look into this cartoon, you would see that various manifestations of gastrointestinal involvement have been captured in the slides, which can, if you take, let's say, diarrhea, one of this thing, most important thing, as I mentioned, maybe around 90% of the PLHIV would have diarrhea at some point of time during their HIV illness. And if you start with the oral cavity, it's a dysphagia, it could be odynophagia, dysphagia is difficulty in swallowing, as well as rhinophagia is painful swallowing. And you can also have the common symptoms that are associated with many illnesses, both with gastrointestinal involvement as well as with other systemic involvement like anorexia, nausea, vomiting, weight loss, pain abdomen is also very important. Then can be jaundice, hepatomegaly, and there can be anorectal diseases. In addition, there can be gastrointestinal bleeds as well, like hematemesis or melena or frank hematochezia as well. Next slide, please. So if you look into the oral pathology, there are certain conditions has been listed over here. If you can find angular stomatitis is one, or angular chilitis. You can also have candidiasis, which can be oral candidiasis or oropharyngeal candidiasis, and also can be the extension of the candidiasis down the esophagus, where it produces esophageal candidiasis. Also, you can come across cases of acute necrotizing gingivitis or acute necrotizing gingivitis. And oral ulcers are multiple. It could be due to aphthous stomatitis, recurrent aphthous stomatitis. It could be HSV related stomatitis, which can be recurrent as well. And rarely we can come across conditions like Kaposi's sarcoma, non-Hodgkin's lymphoma, which all are seen in the oral manifestations of PLHIV. You can also come across conditions like linear gingival erythema, which is also a kind of gingivitis seen in PLHIV or in persons with immunosuppression, but quite common. It has got high positive predictive value for HIV infection. Next slide, please. So coming to the commonest infection is basically candidiasis, and the commonest clinical form is oral candidiasis or oral thrush. We all know this is caused by a fungus known as Candida albicans. If we look into, remember that in neonates, it's quite common. In neonates, it's quite common in HIV negative population. Even in elderly persons with bad, poor oral hygiene or misfitting denture, they can also have oral candidiasis, although they are HIV negative. But other HIV negative conditions where we need to remember oral candidiasis is seen commonly uncontrolled severe diabetes, persons who are on prolonged antibiotic therapy or high-dose systemic corticosteroids or immunosuppressions or cytotoxic drugs, they can also, and even in cancer patients also, you can come across oral candidiasis. But when we talk about HIV infected subjects, basically oral candidiasis points towards a significant immunosuppression. So it's a marker of clinical immunosuppression that, as we all know, that oral candidiasis qualifies to be a WHO clinical stage 3 condition, whereas angular chilitis is caused by Candida albicans. That's also known as, that qualifies as a WHO's clinical stage 2 condition. And when we talk about esophageal candidiasis, that's a stage 4 conditions. These are all known to us. Next slide, please. So if you look into the picture, it's quite evident. This is basically there are 4 clinical types, and the common types of oral candidiasis. Commonest one is basically the pseudomembranous candidiasis, oral candidiasis, which is also known as oral thrush. And here you can make out, see, white patches, exuberant white patches, milky white in color, and that you can easily scrape off without any residual bleeding. And this typically occurs inside the oral cavity, inside the lips, the uvula, the soft palate, the hard palate, as well as the dorsum of the tongue as well. And this is the area, and there can be extensions into the pharynx, and also, as I said earlier, it can further extend up to the esophagus. So this is the commonest type, and this is very easy to diagnose. And the most important differential diagnosis of pseudomembranous or oral thrush is basically oral hairy leukoplakia, which is a condition caused by a virus, Epstein-Barr virus, but we'll be discussing maybe in the next few slides. And there is also an atrophic candidiasis or erythematous candidiasis, where these exuberant pseudomembranes are lacking, but you see our erythematous glazed appearance typically on the hard palate or the dorsum of the tongue, and it might mimic an atrophic atrophic glossitis as well. But if you scrape and see it under the microscope with 10% QH, the fungal elements are easily seen. So atrophic candidiasis is also, we need to remember that this is not due to vitamin B deficiency, but due to candidal infection. Angular cheilitis, we have already talked about. It appears at the angle of the mouth as orogenital fissures, and this is also one. Very rarely seen is the hyperplastic one. It's seen as an typically well circumscribed, raised, round or oval shaped patches over the dorsum of the tongue, and this is quite characteristic of profound immunosufficiency associated with HIV infection. And the symptoms, they can be asymptomatic oral candidiasis, but the patient might complain of dysgeusia, or there can be altered taste, or often they talk about a burning sensation in the tongue as well. And when there is an extension into the pharynx or down the line into the esophagus, there are often patients complain of difficulty in swallowing or painful swallowing. That's one thing that we need to remember. Next slide, please. Diagnosis mostly is an oral candidiasis diagnosed, most of the condition, as you do in your day-to-day practice, is by clinically, but just looking into the oral cavity, have a good look with a good light source, you can make out and identify this thing. However, you need to differentiate it in PLHIV from oral hairy leukoplakia or oral hairy leukoplakia or OHL, which I said that this is due to a virus, Epstein-Barr virus. There is a typical location of OHL. This is into the lateral aspect of the tongue as well as lateral aspect of the dorsum of the tongue. And the adherent plaques, which there are the ridges on the whitish membrane, and they are quite adherent. If you try to remove them forcibly, they can be removed only with a residual bleed, unlike oral candidiasis. But this is not seen in other parts of the oral cavity, oral hairy leukoplakia. This has got a high positive predictive value of for underlying HIV infection. And the conformation can be examined microscopically for the lab conformation if needed. As I said, by 10% KOH preparation, one can identify the fungal elements under the microscope. Cultures are also can be done into SDA or SDCCA media for Candida, which can help you out in species identification. Treatment, commonly it is done through clotrimazole, either mouth paint or lozenges. You can also use nystatin oral suspension, but commonly in the ERT centers, patients with significant oropharyngeal candidiasis, they are treated with oral fluconazole in the dose of 50 to 150 milligram once daily for 7 days, 7 to 10 days. That's good enough. And the children, the dose is usually 6 milligram per kg per day. That's the dose definitely used. But for esophageal candidiasis, you need to use a higher dose. That's 200 milligram. That's a standardized dose and has to be given for a longer period of 2 to 3 weeks. Next slide, please. As I was talking about, that esophageal candidiasis is a WHO clinical stage 4 condition and diagnosed basically on the presence of oral candidiasis on inspection and looking into the symptoms of the individual. Either the patient complains of dysphagia, where the patient would tell that there is something sticking in the chest, whether it's a food or pills, they are sticking in the chest, or there could be that's dysphagia that the patient tries to explain in their own language, and odynophagia or painful swallowing, they'd be talking about substernal pain after food. That's in that way you can differentiate between dysphagia and odynophagia. And esophageal candidiasis produces more of dysphagia rather than odynophagia, whereas CMV esophagitis, another cause of esophagitis in a common cause of esophagitis in HIV positives with very low CD4 count, that produces more of odynophagia than dysphagia. So anyone with complaints of dysphagia or odynophagia should be evaluated for this. And the diagnosis, as I said, that this is, I think we went back. No. Next slide, please. So unless it is mentioned that only if you come across a person who is complaining of dysphagia or odynophagia and has got visible oral candidiasis, you immediately presumptive clinical diagnosis would be esophageal candidiasis and treat it with fluconazole 200 milligram once daily for 2 to 3 weeks. That should be the our approach in our ART centers. Next slide, please. Next slide, please. So if you look into the endoscope, you can find that the very esophageal candida, I mean, very creamy, the cottage cheese or creamy white appearance of the exuberant membranes, pseudomembranes that extends into the esophagus. That's one issue that we need to remember. But normally we diagnose most of them is clinically. If there is a doubt, if the patient doesn't respond to oral fluconazole for 7 days, then we need to go for endoscopy for further evaluation. So often it is associated with the patient not eating with an consequent weight loss is one issue. And more commonly, this is associated with lower CD4 count, especially if oral thrush is present. And esophageal candidiasis qualifies, as we have discussed, is a stage 4 conditions. And we need to remember other stage 4 conditions often coexist, particularly coexist. TB is often seen, esophageal candidiasis or oral candidiasis often is a concomitant OI with tuberculosis. However, symptoms like loss of weight, lethargy, or any danger sign should not be attributed to esophageal candidiasis alone. There you need to look for evidence of other conditions, other associated opportunistic infections other than the esophageal candidiasis. Next slide, please. Children, this is a little different because unlike adults, they often experience a lot of nausea and vomiting, which is uncommon in adults. And children with esophageal candidiasis may present with dehydration and weight loss. This is important for, we need to remember this. And the classic symptoms and signs of esophageal candidiasis may be absent in children with esophageal candidiasis, particularly those who are receiving on antiretroviral therapy. So we need to remember that the initial nausea and vomiting, if the patients are complaining, HIV are complaining of those things, then we need to look for evidence of candidiasis in oral cavity. So that underscores the importance of examination of the oral cavity in all PL-HIV, whether adults or CL-HIV. Next slide, please. Diagnosis is often made empirically based on symptoms and response to fluconazole therapy or topical therapy, and visualization of lesions plus fungal smear if needed. If there is a facility to do that, 10% KOH doesn't require a very sophisticated lab. Ordinary laboratories can, microbiology laboratories or clinical laboratories can be of help in demonstrating the fungal elements within 10% KOH speciation. And this is the definite diagnosis requires direct endoscopic visualization of the lesions with histopathological demonstration of characteristic candida yeast forms in the tissues that will be requiring and taking a biopsy through upper GI endoscopy. And the confirmation, as I said, requires fungal culture in SDA or Seborrheic dextrose agar or SDCCA media. And we need to remember other possible causes of painful and difficult swallowing. One is in advanced HIV disease, particularly those with CD4 less than 50, CMV esophagitis is not uncommon. Often it is undiagnosed. And as I said, it produces more of odynophagia than dysphagia. And if there is such condition, we need to remember that. In addition, gastroesophageal reflux has to be taken into the differential diagnosis. Other conditions like herpes simplex virus has also been implicated in producing esophagitis, and both CMV and HSV produces ulcers in the esophagus, particularly in the distal third of the esophagus, but which might also extend into the middle third of the esophagus as well. And this is more with herpes simplex, and they are usually painful. These conditions are painful or produces a lot of odynophagia. And there can be other conditions, very rarely TB, Kaposi's sarcoma are also been mentioned, and there can be commonly peel-associated esophagitis among the antiretrovirals. Zidofudin was implicated for that, and doxycycline, the alendronates, and these are the few other drugs which also produce commonly used drugs which also produce esophagitis. Next slide, please. The treatment has already been discussed. Fluconazole 200 milligram once orally for 14 to 21 days, and check the response to treatment after 7 days. If there is a good response, continue the fluconazole for rest of the period. If fluconazole is not effective after 1 week, consider other causes listed earlier like CMV esophagitis or HSV esophagitis. And I missed one condition, that was an idiopathic esophageal ulceration, which is actually counterpart of aphthous stomatitis that seen in the oral cavity. If in advanced immunosuppression, there can be multiple shallow ulcers in the esophagus, which is known as idiopathic esophageal ulceration, which is basically a diagnosis by exclusion of other causes. And so that's one thing. If not responding to fluconazole, treat for HSV empirically with acyclovir 400 milligram TID for 10 days. Majority of those with CMV related esophagitis will develop CMV retinopathy. As we all know that CMV disease produces a whole lot of conditions in the immunocompromised host. In HIV, CMV retinopathy is the commonest manifestation, but we need to remember it also involves the gastrointestinal tract in terms of esophagitis, then the colitis. These are all common as compared to involvement of stomach and small intestine. And it can also involve the lungs that produces CMV pneumonia, or often seen along with co-infection as pneumocystis carinii pneumonia. There can also be involvement of the CNS, encephalitis, as well as polyradiculopathy. So, and there can be involvement of the liver as well. CMV produces hepatitis. So that we need to remember all such conditions. But CMV retinitis and a person with CD4 less than 100, in our own guideline also, it's mandated that one should go for an ophthalmoscopic examination to look for evidence of CMV retinopathy. And if there is a retinopathy, then probably you can immediately start treating with valganciclovir. The treatment of choice is valganciclovir, and then ganciclovir is an alternative, because valganciclovir is available as 450 milligram tablets. The standard dose is 900 milligram BID for 2 weeks for induction, and then 900 milligram once daily. And these are all stage 4 conditions. So there are indications for starting antiretroviral therapy at the earliest after you rule out tuberculosis. Children, the loading dose of fluconazole is 6 milligram per kg on day 1, followed by 3 to 6 milligram per kg once daily for 4 to 21 days, maximum 400 milligram per day. Next slide, please. Angular stomatitis presents as painful cracks at the corners of the mouth. I talked about it, that commonly this is caused by Candida albicans, but other conditions like deficiency of riboflavin, vitamin iron deficiency can also produce angular stomatitis. Even infiltrating denture, malocclusion of teeth can also give rise to angular stomatitis or angular chilitis. And they usually respond well to 10 days of antifungal treatment, being commonest being the Candida, which is the stage 2 condition. Next slide. Oral ulcers, there can be oral aphthous ulcers are quite common in HIV positives, and they usually appear one or multiple ulcers, superficial, shallow ulcers, very much painful on the mucosa of the mouth or inside the lips, and sometimes the tongue as well. And the cause is unknown, presumed to be viral. They are at times persistent when the CD4 is low, and they are very painful. And this might aphthous occurs in immunocompetent adults as well, that we know, and these are not uncommon conditions. But in PLHIV, advanced immunosuppression, they tend to occur in more frequently. Recur more frequently is one. Secondly, lesions tend to be larger as compared to immunocompetent adults, and they are often prolonged. Topical steroids are often used to treat them, but the condition is effective with appropriate start of antiretroviral therapy. Herpes simplex virus, the primary or the first episode virus produces this stomatitis, and there can be involvement of the gingiva as well. They usually present as shallow, small vesicles that rupture quickly and produce shallow ulcers or blisters that are quite painful, extensive, and that might be recurrent as cold sores, often on the leaves. And they the pain has to be, you need to treat them appropriately. The treatment is basically good oral hygiene, antiseptic mouthwash, and give acyclovir 400 milligram 3 times daily for 5 to 10 days. In the children, the dose of acyclovir is 15 milligram per kg per dose orally 5 times a day for 7 to 10 days, maximum dose being 200 milligram, and may decrease the duration of illness if you start early in a phase of herpetic gingivostomatitis, particularly if you start within 72 hours at the onset of symptoms. Topical acyclovir, which is available in the market, is actually ineffective. That we need to remember. So if you have to treat someone for HSV stomatitis, you need to treat with oral acyclovir. The valacyclovir or famciclovir are the alternatives for acyclovir. These are also available in the market. Next slide, please. This is an interesting slide. This has already mentioned about primary syphilis, which we know the chancre is seen commonly in the genitalia, but here there can be an extragenital chancre. That's why it has been shown over here. So it can also be a painless ulcer over the tongue. The ulcer of primary syphilis, and I think that's there's a typo here. It would be a chancroid. They look very similar, but the key difference is that in the syphilis or the chancre, primary chancre is actually painless, and the base, if you put on a gloves and palpate the ulcer, the base is found to be typically indurated in primary chancre, whereas in chancroid, which is due to Haemophilus ducreyi and the bacteria, there the lesions are actually painful, usually multiple chancroids, and then the lesions are actually shallow ulcers, painful ulcers, and without any induration at the base. There can be unilateral drained lymphadenopathy in case of chancre, and chancroid is commonly associated with bilateral lymphadenopathy, and often that is painful. However, To differentiate, we always ask for a VDRL or RPR to confirm whether an ulcer is due to syphilis, and VDRL, a titer of 1:8 and above, is considered to be positive and should be treated with injection benzathine penicillin, as we all do, 2.4 million units intramuscularly, deep intramuscular, divided in each buttock once weekly for 3 consecutive weeks. Next slide, please. Next slide, please. Kaposis sarcoma, although distinctly it's uncommon in Indian context, but there are multiple case reports from India. So we need to know that Kaposis sarcoma can have some oral manifestation. It can involve the mucocutaneous system, as well as the there can be lesions, involvement of the respiratory tract, as well as the gastrointestinal tract, and there can be oral lesions as well. Typically they produce a purple fleshy swelling either on the gums or on the roof of the mouth, which often bleed on pressure or touch, and if present on the palate or oral cavity, they might indicate involvement of pulmonary or the GI tract. So there one has to go for further evaluation with the chest X-ray, endoscopy, etc. has to be done, and hemoglobin has to be checked, as if the patient as recurrent bleeds from these lesions of Kaposis sarcoma may lead to anemia, particularly the occult bleed from the gastrointestinal tract. Diagnosis is basically lesions appearance of the lesion, the distribution, and the typical histopathological appearance. We all know that human herpes virus 8 or HHV 8 is the causative agent of Kaposis sarcoma. And the treatment, as we all know, this is a stage 4 clinical condition, so the patient has to be on antiretroviral. If naive ART has to be started, is already on ART for more than 6 months, then the patient has to be evaluated for treatment failure and request for an urgent viral load. If failing first line, switch to second or third line as appropriate, following our own guidelines. In addition, the patient has to be referred to an oncologist for appropriate chemotherapy. Because these days chemotherapies are available. Earlier on, local treatment used to be preferred, but these days systemic chemotherapy is being done, particularly that's pegylated anthracyclines like daunorubicin is often used to treat the condition with good results. And of course, antiretroviral therapy has to be started, because often seen there has been documentation of regression of lesions to a large extent following institution of antiretroviral therapy, even without chemotherapy for the condition. But then again, chemotherapy is now available, and this pegylated vinblastine is quite well tolerated and results in good response. Next slide, please. Necrotizing gingivitis, I was talking about it, gingivitis or gingivostomatitis. Basically, there is involvement typically interdental papillae, which got there are ulcers in the interdental papillae with inflammation, and typically there is very foul smelling or malodorous breath and excruciatingly painful condition. Patient is often unable to take anything by mouth, as well as often unable to talk even. So such painful condition. So, and the prevention and good maintenance of oral hygiene is important, but in a diagnosed case, one has to use frequent antiseptic mouth washes is important. And these are fusobacteriums and anaerobes are actually involved for acute necrotizing ulcerative gingivostomatitis. They're often a combination metronidazole as well as penicillin derivatives like amoxicillin or coamoxiclav are often combined together to treat the condition, and one has to take care of the pain as well. You can use paracetamol at a higher dose, or a combination of paracetamol or codeine or tramadol, etc. And it's a stage 3 condition, And if not managed properly, there can be loss of teeth as well. Next slide, please. So these are all the causes of odynophagia, like fungal, commonest being Candida, rare is histoplasma, viral, CMV commoner than HSV, idiopathic HIV ulcers is the one condition. Gastroesophageal reflux is quite common in our day-to-day practice, which is often seen in other patients as well. And drugs like NSAIDs, zidofudine, doxycycline, etc. involved. And the less common ones are bacteria, fungus, virus, parasites, etc. Amongst the bacteria, TB has been mentioned, so also Staphylococcus, and the fungus, histoplasmosis, and the viruses, Epstein-Barr virus, and the parasites, Cryptosporidium. Next slide. So I think I have finished this section, and now I would like to hand over to Professor Jaya Chakravarty for taking through the further slides of this presentation pertinent to diarrhea and other intestinal parasites. So over to Professor Jaya Chakravarty, please.
Thank you so much, sir, for introducing the topic as well as giving a very nice overview of oral pathologies in HIV. But now I come to diarrhea and other intestinal parasites. Here we'll discuss, as Dr. Guha already told you, that diarrhea is one of the commonest manifestation of HIV, and most HIV patients will have diarrhea in their lifetime. And most of the time when a person has a prolonged or chronic diarrhea, we think about HIV and an HIV testing is done. Next slide, please. So we'll start with some definitions. I think you had some in your MCQs too. So what is diarrhea? Diarrhea is 3 or more loose or liquid stools per day, or as having more than what is normal for a person. It may be associated with other symptoms like nausea, vomiting, fever, and abdominal pain. Even it is almost the same in children, except for in those in infants. In infants, it is an increase in stool frequency to twice the usual number per day in infants. And for older children, it is the same as for adults. It is 3 or more loose or watery stools per day. Now, the other word is dysentery. Now, everybody knows dysentery is if there is associated visible blood in stools, it is termed as dysentery. You were asked about persistent diarrhea. And what is persistent diarrhea? It is a diarrhea which starts acutely, but may persist beyond 2 weeks. And usually there are 5 to 15% of cases of diarrhea which are persistent diarrhea. And chronic diarrhea, like for in adults, we usually say it is the diarrhea which persists for more than 30 days. But for you, the definition which has been given is a diarrhea which is insidious in onset. It is not acute in onset as in persistent diarrhea, but it is insidious in onset and persists for more than 2 weeks duration in children. And the term chronic diarrhea is not synonymous with persistent diarrhea. Persistent diarrhea is a little bit different, that it started acutely and persisted beyond 2 weeks. And chronic diarrhea is started insidiously and it persisted beyond 2 weeks in children. But for adults, most of us, we use 30 days for chronic diarrhea. Any diarrhea that persists for more than 30 days. Next, please. So the consequences of diarrhea, you know, in children is dehydration and malnutrition, and it is a vicious circle. It goes on and on. If the more malnutrition you have, you'll have more diarrhea and more dehydration. Next. So here they have actually classified diarrhea into inflammatory and non-inflammatory diarrhea. Inflammatory diarrhea is that which occurs when pathogens invade the wall of the large bowel, causing an immune response and mucosal bleeding. So it can also be said as a large bowel diarrhea. That is how we can classify in adults large and small bowel diarrhea. And non-inflammatory diarrhea is a consequence of pathogens that superficially invade the epithelial layer of the small bowel and cause increased secretion of water and electrolytes into the lumen. So for our students, the way we say it is a large bowel diarrhea is small volume diarrhea with mucus, blood, abdominal pain, and non-inflammatory diarrhea or small bowel diarrhea is a large volume diarrhea. Okay, so that is another way of classifying small bowel and large bowel diarrhea, besides classifying them as inflammatory and non-inflammatory diarrhea. Next. So we come to the causes of acute diarrhea. So acute diarrhea again can be inflammatory or non-inflammatory. For acute inflammatory diarrhea, most of the pathogens are bacterial, like Shigella, Salmonella, Campylobacter, E. coli, and Clostridium difficile. And it could be parasitic like amoebiasis, or it could be viral like cytomegalovirus disease. As Dr. Guha was just telling you, that cytomegalovirus can affect any part of the GI as well as the liver as well as the retinopathy you know of. Now, acute non-inflammatory diarrhea is usually viral diarrhea, like rotavirus, enterovirus, and norovirus, or it could be due to parasite like Giardia, which actually resides in the small bowel. Next, please. Whereas chronic diarrhea for HIV especially is caused by a lot of protozoals. Okay, so again, chronic diarrhea can be divided into chronic non-inflammatory diarrhea, and usually these organisms are in the small bowel, so it is like a small bowel diarrhea, that means large volume watery stools, and they are mainly in HIV. They are caused by protozoans like Cryptosporidium and Cystoisospora. And Microspora is no longer a protozoal. It is actually reclassified into fungal and Cyclosporidium. And it can also be caused by Giardia, which is a protozoa, and Strongyloids, which is a nematode. So it's a variety of organisms, not the common ones you see, but protozoal and nematodes and some fungal also. Now, persistent diarrhea in children with HIV may be due to malnutrition, may be due to some sort of pathogenic E. coli, like aggressive and adherent types. And sometimes in children, there could be a prolongation of acute diarrhea because of cow milk protein allergy. And many times it may be due to antibiotic associated diarrhea because of bacterial overgrowth, or it could be due to Cryptosporidium persists. So Cryptosporidium can start as an acute and then it may persist for a long time in CLHIV. Next. So what are the complications? You already know. I don't have to tell you much in detail. So naturally, the first thing is dehydration, and it can cause acute kidney injury, and it can cause electrolyte abnormalities like hypokalemia, hyponatremia, and chronic diarrhea can actually cause malnutrition. And at times, the bacterial infections, it may cause systemic bacteremia as well as systemic sepsis, and that can cause a lot of death too. Next. So we'll start with the bacterial enteric infections. Next. So the gram-negative bacterial enteric infections are much commoner in HIV-infected adults than in general population. And as you are on ART, the frequency decreases, and it is greatest. Naturally, it will be most in patients who have AIDS or have a very low CD4 count of less than 200. And the common organisms are Salmonella, Shigella, and Campylobacter. But it has been seen in studies that Clostridium difficile associated infection, which usually occurs in patients who have been admitted, and it is usually antibiotic associated. But in HIV, it is a common organism, and usually it occurs in those with low CD4 count too. Now, most of these organisms actually are acquired by ingestion of contaminated food and water, so that it is very important to know that and reinforce in every visit to the PLHIV that they should have access to clean water and wash their hands before food. Next. And the clinical manifestation of these bacterial infections could be a self-limited gastroenteritis, or it could be more severe and prolonged diarrheal disease associated with fever, bloody diarrhea, and weight loss. A third way it can present is bacteremia associated with extraintestinal involvement with or without concurrent or preceding GI illness. And this is the most severe form this bacteria could take. Next. So for the diagnosis, naturally you need to have a very good history, including the medication history. Not because many of the diarrheas can be due to certain drugs you are taking, especially the lopinavir, which can cause a lot of diarrhea. Diagnosis is established through cultures of stool and blood. And blood should be cultured, especially if you are thinking of systemic disease due to gram-negative enteric pathogen. And blood cultures should be obtained from, that is why it should be done. And before you start any antibiotic, it should be taken both for stool as well as blood. And the diagnosis of Clostridium difficile infection is complicated. Either you need to do an ELISA or you can do a PCR-based test. ELISA looks for the toxins, and the PCR, it looks for the toxin gene of Clostridium difficile. And it's not very easy, and most of the labs don't do it. And because it has a very, very separate treatment as compared to the other bacteria, special effort needs to be taken actually. And at times, if you have not made a diagnosis from the stool culture and bacteria blood culture, endoscopy and biopsy needs to be done, especially if it is if the diarrhea is due to microsporidia, because it's very small. Cryptosporidias is usually, you can see the oocysts in the stool, but CMV again has to be diagnosed by a biopsy from the colon, and MAC can be diagnosed by the biopsy, but the best way of diagnosing MAC infection is actually a blood culture. And especially MAC will not just cause gastroenteritis, it will also have effect in the bone marrow. And so blood culture and bone marrow culture is very, very good for MAC. So if stool cultures fail to yield enteric bacterial pathogens in patients with symptoms of proctitis or colitis, you should look for and evaluate for STDs, and they should, because it might be due to other STDs and you're not giving the right treatment. That is why it is not resolving. Next. So how do you manage? Of course, the first and foremost for any diarrhea is rehydration therapy. And for any bacterial infections, naturally, we know anti-motility drugs should be avoided. And a fecal specimen should be obtained, as I told you, before you start any antimicrobial therapy. And if you get a positive stool samples, then antibiotic susceptibility should be done so that you can give the exact antibiotic and give it at the right dose. And empiric treatment for bacterial infections should be done for PLHI with advanced HIV and clinically severe diarrhea. That means more than 6 liquid stools per day or bloody stool, or the patient has systemic features like fever or chills. For PLHI with persistent diarrhea, that is more than 14 days, but no other severe clinical signs like dehydration or blood in stool, antibiotic therapy can be withheld until you can make a diagnosis what is happening to the patient. And the preferred empiric therapy is ciprofloxacin. Either you give orally or IV, depending upon whether the patient can take it or the patient has severe septicemia. And the alternate to it is ceftriaxone. Next. If you, most of therapy actually does not change for either Salmonella infection or Shigella or Campylobacter, but the duration of therapy does change. If the CD4 is more than 200, then the duration of therapy is around 7 to 14 days. And if the CD4 is less than 200, the duration is more prolonged to 2 to 6 weeks. And if the patient has bacteremia, naturally you will give it for a longer. Minimum duration you give it is 14 days. So salmonellosis, again, ciprofloxacin is the preferred, but if in your lab there's a lot of salmonella which is resistant to ciprofloxacin or any of the other fluoroquinolones, I think ceftriaxone is a better drug to give and give it at a better dose. So that depends upon what is the prevalence of antimicrobial resistance in your area. And your microbiology can tell you that. Like, we would always use a ceftriaxone instead of ciprofloxacin. Next, please. As I told you, the drug of choice does not change, but in Shigella, you can also give azithromycin or trimethoprim sulfamethoxazole. And again, the duration depends upon whether you have bacteremia or it is just an isolated gastroenteritis. Okay, next, please. Same for Campylobacteriosis. The drug of choice is ciprofloxacin or azithromycin, and the duration, as I told you before. Next, please. Now, Clostridium difficile, I told you, the treatment, management, diagnosis is also different. You just don't culture it. You have to go for a PCR and ELISA. And the treatment is also totally different. You can go for oral vancomycin, which is available at the dose of 125 milligram 4 times per day for 10 to 14 days. Or you can go for metronidazole, which is easily available. Vancomycin may not be available where you stay. So we can go for metronidazole, 500 milligram 3 times per day for 10 to 14 days. Next. So now we come to management of diarrhea in CLH, children living with HIV. Next. So what are the objectives in the assessment of children with diarrhea? So we first try to determine the type of diarrhea, whether it is acute watery diarrhea, and that is whether it is a small bowel diarrhea or a large bowel diarrhea, whether there is dysentery involved, or this is started as an acute but is now persisting, or persistent diarrhea is there. Then, of course, you look for dehydration and other complications like renal complication. Then you look for assess for malnutrition, because I told you before also, diarrhea can lead to malnutrition, and malnutrition again can increase the frequency of diarrhea. And you also have to rule out non-diarrheal illness, especially systemic infections, and assess the feeding of the child both before and after and during the illness. Next. And history taking should include what was the onset of the diarrhea, what is the duration, number of stools per day, whether there's blood or not, whether it's associated with vomiting, whether the child can take orally, whether there's any systemic signs like fever, cough, or any altered sensorium, convulsions, etc., or has there been recent measles, because that can precipitate diarrhea in children. And it is very, very important to take the history of how the child is feeding. So as I told you before, what was the type of feed they were taking? Was it breast milk, or what is the type of food being taken during the illness? Okay, and the feeding practices. You have to look into the drug history, as I told you, and you have to see whether the drug is causing diarrhea, or whether the child has already taken certain opioids or anti-motility drugs, okay, which may lead to abdominal distension. And of course, you need to know the immunization history, especially measles and rotavirus vaccine, whether they have taken those or not. Next, please. And you have to assess for dehydration, okay, and look whether the child is alert, restless, lethargic, irritable, or unconscious, because your whole management depends upon the dehydration status of the child. So appearance of eyes is also very important, whether it looks normal or sunken. It is extremely important to assess whether the child can drink water or take ORS solution orally, because whether you want to give the child oral ORS or just IV therapy depends upon all the assessment you do now. And you actually feel for skin turgor, where you just pinch the skin, and normally our skin comes back to normal within 2 seconds. But if the child or a person is dehydrated, the skin will flatten down very slowly. So it will take more than 2 seconds, and that indicates dehydration. Next. I know this is an extremely busy slide, but what I want you all to focus is in the lower part of the slide, where there's the written plan A, B, and C. So it's very clear that if the child does not have any dehydration, is well and alert, with normal eyes, crying normally with tears coming out, with moist mucous membrane, not thirsty, drinks normally, and skin pinch goes slowly, that means the child is okay, not very dehydrated, can take ORS, and then can be sent home with the very clear-cut direction about the warning signs and when the mother should bring the child back to the clinic. Okay. Other than that, if the child is restless, irritable, have sunken eyes or dry mucous membranes, or is thirsty and drinking very eagerly, that shows that the child has some sort of dehydration but still can take orally. These children cannot be sent home. They have to be monitored in the hospital just to see whether the child is improving or deteriorating. And those child with the severe dehydration, there's a typo. The second one is moderate, there's some dehydration. And the last one is severe dehydration, where the child is lethargic, unconscious, very sunken eyes, dry mucous membrane, and cannot drink, okay, or drinks very poorly. that child needs an IV rehydration therapy and has to be managed in the hospital. So depending upon the degree of dehydration, you decide whether the child has to be hospitalized or be given home-based treatment. And if you're sending for home-based treatment, you have to instruct the caregiver when to bring back the child and to know and to tell the doctor if the child has any serious signs. Okay, next. So classification of dehydration is one when there is fluid loss but no actual dehydration and the fluid loss is just less than 50 milliliters per kg. There may be some dehydration when the fluid loss is around 50 to 100 ml per kg fluid loss, and there's severe dehydration in a child when the fluid loss is more than 100 ml per kg. Okay, so this is how they classify dehydration. Next, in children, of course. And of course, when you are examining, besides assessing for dehydration and consciousness and ability to drink of the child, you also have to look for features of malnutrition that includes anthropometry for weight and height and examination for edema, wasting, and signs of other vitamin deficiency like the skin, hair, tongue, etc. And you should look for systemic infection and look for presence of cough, high-grade fever, fast breathing, suggesting pneumonia, or high-grade fever with splenomegaly, maybe malaria or other tropical infections, and look for other fungal infections like Sir told you just now how to look for candidiasis. And so these all other examinations also should be done in the child. Next. So for when a child has acute diarrhea, so stool microscopy or stool culture or doing a stool pH and reducing subject does not actually help. Okay, even CBC, ABG, serum electrolytes and renal functions, they also are to be done only if the child has some systemic involvement, has pallor, tachypnea, altered sensorium, seizures, paralytic ileus or oliguria. Only then you should go for this. Okay, so most of acute diarrheal episodes, most of the you don't need actually any of the investigations in an acute diarrheal episodes. Okay, and it can be diagnosed and managed effectively without any lab investigations. Next. So how do you manage acute diarrhea? Everybody knows hydration, rehydration is the main thing, and then ensuring the child is adequately fed. And don't stop feeding. Many people do that. They just stop feeding if there is diarrhea. The IAP recommends oral supplementation of zinc in any cases of acute diarrhea in children, and early recognition of danger signs and treatment of complications needs to be done as a clinician. Okay, next. So in children with no dehydration, you can treat with WHO ORS and home available fluids, and the mother has to be counseled how to give, how to prepare, and how much to give the child depending upon the age and amount of and the dehydration level. Now, the mother does not have access to WHO ORS. Home available fluids can also be used, especially if they have salt included in it, like maar bhat, that is called salted rice water, or salted yogurt, or vegetable or chicken soup with salt. Sometimes even these fluids without salt is also accepted, like unsalted soup and unsalted rice and plain water. But commercial beverages like fruit juices and sweetened teas are not acceptable as a home-based rehydration therapy. The mother has to be told about the danger signs, as I've told you many times repeatedly now, like if the diarrhea persists beyond 3 days, if the frequency and volume of stool increases, if the child is having repeated vomiting, increasing thrust, and is refusing to feed, or if there is fever or blood in stools, immediately the mother should bring, or the caregiver should bring the child back to the hospital. So these are the danger signs where the diarrhea becomes worse or persists, or the child cannot have food and is vomiting. So these you have to bring back the child. Here on the side, you can look into the amount that has to be that should be given per day, as depending upon the age of the child. Next, please. Children with some dehydration should be treated at a hospital. So, as I told you, no dehydration, go back home with ORS. Some dehydration, give oral therapy, but in hospital. Okay, and children with severe dehydration, they have to be given IV fluids urgently and promptly. Next. Feeding. Many people, as I told you, think that they should food should be restricted during diarrhea, but that is not true. If you feed early, it not only decreases the stool volume, but also facilitates absorption of sodium and water, and also facilitates early gut epithelial recovery and prevents malnutrition. So feeding should be proper and started. It should not be stopped basically. Okay. Once the child status starts improving, a higher than recommended intake should be given to complete catch-up, the catch-up growth, okay, to facilitate the completion of the catch-up growth, because the child might have lost weight and have some sort of malnutrition during the episodes of diarrhea. Next, please. As I told you, IIP recommends zinc supplementation in management of diarrhea in children at a dose of 20 milligram of elemental zinc per day for children older than 6 months of age for a period of 14 days. So it is why zinc, because it helps in decreasing the severity and duration of diarrhea and risk of persistent diarrhea. For those who are having persistent vomiting, symptomatic treatment with a single dose of ondansetron can be should be given. Next. So there are certain things you need to know, that antibiotics are not routinely indicated for the treatment of acute diarrhea, because most of them will be due to viruses like norovirus, rotaviruses, and they are all self-limiting disease. Only thing you have to do is rehydrate the child. But antibiotics are indicated in bacillary dysentery. That means any diarrhea with stool with blood in it or mucus in it. If it is a cholera, that is, you have a rice water like diarrhea, which causes very, very severe dehydration, amoebiasis and giardiasis. So these conditions you need to give. Other than that, most of the diarrhea in children are self-limiting due to virus, and it is non-inflammatory mainly. When acute diarrhea is a manifestation of systemic infection in a malnourished or prematurely born or young infant, age-appropriate systemic antibiotic is recommended. Because I've told you before also, malnutrition leads to diarrhea, and diarrhea again leads to, it's a vicious cycle. So that needs to be treated with a systemic antibiotic. Anti-motility drugs and binding agents are not recommended and can be harmful to infants and children, should not be given. Okay. Neither should anti-secretory agents like resicadotril and probiotics. They are not routinely recommended. Next. Now, as I told you before, dysentery needs to be treated. So what is the first line of treatment? If the child is very sick, give IV ceftriaxone. And if the child is stable, then you can give ciprofloxacin oral or cefixime. Okay. So, and then the child should be monitored for clinical improvement within 48 hours. That means the frequency of stool should decrease, the blood in stool should decrease, and there should not be any fever. But if there is no improvement in 48 hours, again, you can upgrade the antibiotic to ceftriaxone. Shigellosis, and when I was telling about shigellosis and even Campylobacter for that matter, oral azithromycin can be given for 3 days. But we don't have a very good experience, or the expense is limited. So it's better to give ceftriaxone or ciprofloxacin. If you don't want to give ciprofloxacin in children, you can go for cefixime. Okay. Now, for children with amoebic dysentery, metronidazole or tinidazole is the drug of choice. Any young child presenting with blood in stools and persistent abdominal pain should be suspected to have intussusception and evaluated accordingly. That means take a surgical opinion. Okay, don't leave it as such, because that is a surgical emergency. Next. So principles of management of persistent diarrhea. That means it started acutely, did not resolve. in 14 days, it is persisting beyond 14 days. So of course, you will correct the dehydration and electrolyte imbalance as well as hypoglycemia. Then here, as I told you, acute diarrhea, it does not need to be evaluated with lots of stool microscopy, culture and all those, because most of them are self-limiting. But persistent diarrhea needs to be evaluated for infections using appropriate investigations. And then according to the results, you can manage accordingly. And of course, you should focus on nutritional therapy because especially in children, nutritional therapy and catch-up growth and all this needs to be taken care of, because once they go downhill very, very fast. Next. Now we come to specific organism, cryptosporidiosis. Next. Now, Cryptosporidia, it actually infects the small bowel. So naturally it causes acute or subacute. It can be a cause of persistent diarrhea too. Watery diarrhea, which may be accompanied by nausea, vomiting, or lower abdominal cramping. Now, the disease severity can have a very wide range. Patient may be asymptomatic, or it may have, the patient may have profuse cholera-like diarrhea. So, and actually, naturally, the symptoms are much more severe in immunosuppressed patients, because cryptosporidiosis does cause diarrhea in immunocompetent too, and usually it's a self-limiting diarrhea. And fever may be present in 1/3 of the patients, and malabsorption is common. But it can also affect the biliary tract as well as the pancreatic duct. So it can cause the sclerosing cholangitis and pancreatitis, especially in those with prolonged or persistent disease, as well as those with low CD4 count. Cryptosporidiosis, persistent diarrhea due to cryptosporidiosis usually occurs in patients in stage 4 of HIV. Next. So how do you diagnose? You can do a stool microscopy, and you can stain the stool with modified acid-fast staining, or of course you can do direct immunofluorescence too. And if you concentrate the stool, we have a much better chances of diagnosing cryptosporidiosis. And this is the most commonest way of diagnosing, but of course you can do ELISA and immunochromatographic test. And what you can see on the right side of your slide is the red colored ones are the cysts of the cryptosporidia. And if the person has a very mild disease, then you need to do a repeated stool sampling. But if the patient has a severe disease, only a single sample is usually adequate to identify cryptosporidiosis, provided you do the right staining. Next. So how do you prevent? So because as I told you, chronic cryptosporidiosis usually occurs in patients with very advanced immunosuppression. Immediate initiation of ART is the thing. It's the best way of stopping any of the diarrheas in HIV, especially cryptosporidia, azospora, macrosporidiosis. These all don't have a very great treatment. But if you increase the immunity of the patients and start ART early, and then you will prevent recurrence or persistence of the disease. Now, treatment again is oral rehydration and replacement of electrolyte loss, rapid ART initiation. There are certain OIs like cryptosporidiosis, PML, which do not have very great treatment. Here, the treatment is starting ART immediately. So, nitazoxanide can be given. It can be given twice daily with food for around 14 days. Paromomycin can also be given, but we usually don't, because we don't have the availability of oral paromomycin in our setup. But nitazoxanide is very commonly available. Next. Now, cystoisosporia, isosporiasis. Previously, it was known as isosporiasis. Next. Again, it affects the small bowel, and it causes watery, non-bloody diarrhea with a lot of abdominal pain, cramping, anorexia, nausea, vomiting, and low-grade fever. And again, this can cause profuse and profound diarrhea in immunocompromised patients, leading to severe dehydration, electrolyte abnormalities like hypokalemia, weight loss, malabsorption. Diagnosis is similar to cryptosporidium. You have to take an acid-fast, do a modified acid-fast staining of the stool, and you can see the oocysts. It's a little bit bigger than what you saw for Cryptosporidium. And you can also diagnose the infection by detecting the oocysts in the duodenal aspirates. As I told you, both Cryptospora as well as Cystoisospora, they are in the upper small bowel. So you can put an endoscope and take out specimens. And profile prevention, the cotrimoxazole work prophylaxis has a protective role for isosporiasis also. Next. The treatment is trimethoprim sulfamethoxazole for 10 days. And usually we give it at a dose of twice daily for 7 to 10 days, but you can give it at a higher dose also. And you need to give it as an IV if the patient has a lot of malabsorption. So if the patient is allergic to sulfa or intolerant to sulfa, then pyrimethamine and leucovorin or ciprofloxacin may be given, but trimethoprim sulfamethoxazole is the drug of choice for this isospora, cystoisospora. Next. So chronic maintenance therapy, actually you're already giving trimethoprim sulfamethoxazole for prophylaxis for PCP and other things, so that will also work. Here, the dose is actually, dose required is actually less. You can give it only 3 times weekly, but for PCP, we're already giving it for once daily, so that should work for everybody. Okay, next. Now, what are the other causes of diarrhea in PL-HIV? Next. So there could be other infections like Mycobacterium tuberculosis and or Mycobacterium avium complex or MAC. So Mycobacterium tuberculosis usually affects the terminal ileum, and you may have microabscesses, lymph node involvement. And as I told you, MAC can have pancytopenia, MAC can have GI, lymph node, lymphadenopathy, and even splenic microabscesses. Now, and MAC can easily be diagnosed in blood culture or bone marrow culture. But for TB, Mycobacterium tuberculosis, you need to do, if you can take a specimen out of the lymph nodes or from the microabscesses in the spleen and do a CBNAT, that would be helpful. And if you're thinking of Mycobacterium infection and your CBNAT is negative, while your AFB stain is positive, that shows that the infection is more likely to be MAC. The treatment slightly differs, so that diagnosis needs to be made. Mycobacterium in blood culture actually comes up and becomes positive within 7 to 10 days. So blood and bone marrow cultures do help in the diagnosis of Mycobacterium avium complex or MAC infection. And Dr. Guha already told you a lot about CMV disease. So that's just a repetition of what he said. CMV can affect any part of the GI, okay, besides retinopathy and involvement of the sacral nerve or CNS involvement in the form of encephalitis. CMV can affect any part of the GI in the esophagus, as Dr. Guha told you, can cause ulcers or esophagitis, but it commonly causes colitis too. And though it can cause ulceration of both small and large bowel, colitis is more common. And the patient usually has a very non-specific presentation like weight loss, anorexia, abdominal pain, diarrhea, malaise. And if you take, you can diagnose it by taking a biopsy. And of course, as Dr. Guha said, if you don't have the facility to do a biopsy or put a colonoscope and do a biopsy, then always look into the eyes, and we should look into the retina of patients with CD4 less than 100. And if you diagnose CMV retinopathy and the patient is having a lot of diarrhea, then it could be due to CMV, colitis, and so CMV involvement of the small intestine too. And Dr. Guha already told you about this. So the management is just like CMV retinitis. You start with ganciclovir 5 milligram per kg IV BD and switch to valganciclovir 900 milligram twice daily once the patient can absorb and tolerate the oral therapy. Okay. So when you have chronic diarrhea, think about cytomegalovirus, and the CD4 count is very low. Think about cytomegalovirus MAC infection, and of course, tuberculosis can occur in any CD4 count. So, next. So there are certain parasitic infection you should really think about. So there's a nematode Strongyloides torcularis. Now this the filariform larva of strongyloids can disseminate widely, cause auto-infection and hyperinfection. And when you have a lot of auto-infection, the parasite burden will increase, and that is called a hyperinfection syndrome. And it can cause diarrhea, it can urticaria. And in advanced HIV, it can even cause meningitis and multi-organ failure. But strongyloids are very easily treated by ivermectin, either at the dose of 200 microgram per kg as a single dose for 1 or 2 days. If ivermectin is now available everywhere. Actually, it can normally you will get it in combination with albendazole. So if you cannot get ivermectin, then you can give albendazole 400 milligram twice daily for 7 days. But ivermectin is the drug of choice. It works better than albendazole any day. So giardiasis also should be, again, giardia causes a lot of bloating, diarrhea, because it affects the small intestine. So metronidazole is the drug of choice. You give it for a shorter duration of time, then you give it for amoebiasis, that is 3 days. And dose for children is 15 milligram per kg per 24 hours, divided into 3 doses for 5 to 10 days. And you can, if you don't want to take metronidazole, you can take tinidazole 2 grams as a single dose too. So for adults, that is 2 grams, but for children more than 3 years, you can give 50 milligram per kg, a maximum of 2 grams as a single oral dose. So giardia is easily treated. So next. Besides the parasitic infection and uncommon infections like MAC, Mycobacterium tuberculosis, and CMV, there are certain non-infectious cause of diarrhea. And as I told you, it could be drug-induced, like lopinavir very commonly causes GI problems, and especially diarrhea. And when you have it is better to switch the patient from lopinavir to atazanavir if you think it is due to lopinavir. And of course, you all know that if you're giving a PI like atazanavir or lopinavir, you cannot give rifampicin if ADT is being given. So you have to change the therapy to rifabutin. Okay. And loperamide can be given here when you're quite sure this is due to a drug-induced and not infective diarrhea. There's a role of giving loperamide and decreasing the frequency of stool. I will not go into a lot of Kaposi sarcoma because Dr. Guha gave a very detailed slide about Kaposi sarcoma. As he already told you, it can affect the small bowel, large bowel, and including the oral cavity. And it can cause severe bleeding at times. And that is why you need to look into anemia. And what you need to do is give chemotherapy and start effective ART, because Dr. Guha already told you that ART is also going to decrease the size of the lesion in Kaposi sarcoma. Next. A few 2 slides left for the anal lesions, which, as Dr. Guha also told you, it is very neglected because we usually forget to look into it or give it much significance. But the patients are really, really bothered about these lesions. These anal lesions could be infective or it could be non-infective. Next. So non-infective anal lesions could be perianal hematoma, which actually manifests as, usually the patient have piles and is constipated and presents with a painful lump, and which worsens on passing stool. And on examination, it is a painful purplish swelling, which is clearly visible in the anal skin due to the rupture of the blood vessel under the surface of the anal skin. It is bit painful due to because of the presence of blood, the skin has been stretched. You don't do anything here. You just leave, because it is a hematoma, it will absorb on its own, but you can soften the stool and make life easy for the patient, and you can apply local anesthetic so that that will help relieve the pain in the patient. The other is a thrombosed pile, which is a surgical emergency. It is the patient comes with acute onset, painful, swollen lump in the anus, and often with bleeding. It is red, tender, fleshy swelling emerging from the anus, but not connected to the outside skin. And here you need to refer to surgery, and they will do the needful. And similarly for perianal abscess, usually you have to refer to surgeons for incision and drainage. But if there is perianal fistula, usually perianal fistula are painless, and but there will be anal discharge and itching, and you can see the fistulas on opening the anus. And most common cause you should all know is of perianal fistula is tuberculosis. So start TB treatment, and it is if you do a lot of surgery, and that is going to cause more complications. So you start ATT and see whether that is improving or not. Okay, so chronic discharging perianal sinuses, most likely it is to be tuberculosis. So treat rather than sending to surgery and getting a whole mess up of everything. Next, and the last slide, I think. So there are certain infective anal lesions in PLHIV. As Dr. Guha already told you, herpes simplex, it can affect the mouth, it can affect the oral cavity, it can also, and it affects the genitals. So it causes painful vesicles or very painful shallow ulcers. And the treatment is by acyclovir. Somebody had asked before that if you don't have acyclovir, what to give? Then Dr. Guha answered famciclovir or valacyclovir. Now, the other infection which can occur and which is very common in HIV is human papillomavirus, and you know that it can cause not only benign lesions like warts, but papilloma infection can also increase the susceptibility to anal carcinoma. So it looks like warts, it looks like cauliflower, gives a, many of the warts are adhered together, it gives a cauliflower-like appearance. So treatment is usually local ablation or local application of local podophyllin. And at times it can present with anal ulcer, but that is not very common. And then you need to look and diagnose a pre-malignant condition. And how will you do that? By doing an anal pap smear. And as we have seen in our setup, that many of the males, PLHIV, males who are actually, they say they are heterosexual, they're married, but mainly they are bisexual, and they have a lot of HPV infections in their anal canal, and as well as dysplasia. So it is a pre-malignant condition, and a pap smear, anal pap smear needs to be done, and the patient needs to be followed up before it reaches a stage of anal cancer. Now, proctitis is another STD, is a very common manifestation in PLHIV, and it presents with anal itching, pain, discharge, and the severity may range from mild to severe, and appropriate treatment for STDs should be given. And as Dr. Guha already told you about syphilis, it can present with a painless ulcer and primary chancre, and I don't think so. It looks like HPV warts. HPV warts are usually smaller unless and until they've coalesced and become very, very big, like a cauliflower appearance. But of course, every HIV patient should undergo a BDRL test, so or RPR, and get their syphilis treated if positive. So I think I'm at the end of my next slide, please. Oh yes, I think I'm at the end of my slides. So you can go ahead with the post test. Thank you so much.
Yeah, thank you so much, ma'am. Kiran, can we please unmute the participants now?
Done, ma'am.
Thank you. Participants can now unmute themselves, unmute their mics and ask questions. Ma'am, there's one question in the chat box. How do we calculate the fluid loss per kg body weight?
If you had seen the slides I had presented, so on the right hand side of the slide, it was very clearly given. See, fluid needs to be calculated like that only in children, not in adults. Okay. So that was given very clearly. If the child is less than 24 months, how much should be given? Okay. So you're not a pediatrician. So you better if a patient is in severe dehydration or moderate dehydration, there should be a pediatrician who should manage. See, I am an adult physician. Even I would not know the exact amount of fluid to be given to a child. So usually, initially they will give 25 to 50 ml per kg per hour, but then the total fluid requirement should be as per the pediatrician's help. It is not your job to do it.
Oh, there's one more question, ma'am. There is a patient who is unable to tolerate acyclovir. Are there
We've
any
answered that.
alternatives? That
We've
has been
answered
answered.
that,
Oh.
PAM and valacyclovir.
Participants can now unmute their mics and ask questions, if any. Ma'am, I don't think there are any questions. Can we quickly run the post test?
Yeah, please do.
Kiran, sir, can we have the post test, please? Thank you. The post test questions are now visible on your screen. Participants are requested to attempt all the 4 questions. Please scroll through the screen and attempt all the 4 questions. Kiran, sir, we can end the e-poll now. The answers to the post test. Which of the following statements about oral candidiasis is false? The false statement is persisting oral thrush qualifies as stage 4 disease. Persistent diarrhea in CLHIV is identified as acute onset diarrhea and lasts more than 14 days. Which of the following statements about management of diarrhea is or are true? The answer is A and C, that is oral or IV rehydration therapy, if indicated, should be given to patients with diarrhea, and diagnostic facial specimens should be obtained prior to the initiation of empiric antimicrobial therapy. The last question, Kaposi sarcoma is a WHO clinical stage 4 disease. The next sessions are on 29th August and 1st September. 29th August, we have HIV and opportunistic infection, skin and mucous membrane. On 1st September, we have the session on non-communicable diseases and mental health, prevention, screening, and management among PLHIV. Kiran sir, can we quickly run the feedback? Thank you. The feedback form is now visible on your screen. There are 4 questions in the feedback form. Please scroll through all the 4 questions and answer them. I would like to thank Puri sir for the opening remarks. Thank you to Guha sir and Jaya ma'am for facilitating this session. Thank you to all the participants for patient listening. Kiran sir, we can end the e-poll now. Thank you. Jaya ma'am, can we conclude the session now? No, ma'am has left. She's left. Thank you to all the participants. We'll conclude the session now.